and Dr. Aitken Buadromo from Fiji, the SPC. So for those of you who don't know me yet, my name is Chris Bates. I'm the Technical Officer for Cancer Control in the WHO Division of Pacific Technical Support in Suva. And a large part of my work is to be supporting countries and member states with cancer registry development. So I've got the help from the Pacific Health Information Network to run some webinars to guide cancer registry development. So I will very shortly hand over to Professor Joanne Aitken, who is the head of and you'll have to excuse me here, Joanne, I've never heard this pronounced, only seen it written, the Viatel Cancer Research Center.
It's yes, it's the name of a very generous donor, Mr.
Excellent, Viatel. Cancer Research Center, which is the research unit of the Cancer Council for Queensland. Joanne is also the director of the Australian Childhood Cancer Register, and she's been really proactive in setting up and guiding the Toronto Cancer Staging Guidelines, which will be used in the cancer registries, the staging of childhood cancers in the registries that the countries will be setting up. She's on Cancer Australia's Advisory Council and president of the International Association of Cancer Registries. And that's an important one to remember as well for our friends from the Pacific Islands who are setting up cancer registries, a really important resource and a group to be involved with to be able to draw on support from other countries around. So Professor Aitken is also recognized for a lot of work in the epidemiology of skin cancer and childhood cancers, but running the Australian Childhood Cancer Registry is exactly why we draw on her expertise today. And she's going to tell us about why a cancer registry from the general principles. I'll hand over to you. Thank you, Professor Joanne.
Thank you very much, Chris. And it's such a great pleasure to be here today. Hello, everybody. I don't think I know anyone, I don't think, except Chris. So hello. It's lovely to be here and to speak to you today. Before I start, I should just say that I'm a little embarrassed that I think that I've produced a presentation that is probably at too low a level for this distinguished and obviously interested audience. So do forgive me if it's a little too basic for you. I hope that some of it is of interest. I'm going to talk about principles, but most of my talk will be about examples of use of cancer registry data. So, and I'll finish with a bit of a surprise at the end with a new initiative that the Cancer Registry here in Queensland and the Cancer Council Queensland have developed together. So that'll be a video, and I hope that works. So here we go. I'll start to share my presentation with you now. Chris, is that visible for everybody?
Looks great to me. Thank you.
Wonderful. Thank you. Let us know if you can't see that, anyone. So this is the topic that I've been asked to address today. Why a cancer registry? And for me, this is pretty much very much an easy question to answer, because it's about all I do in my working life is deal with cancer registry data, and without that, I wouldn't really have much to do. There are two things I'm going to be focusing on, which I'd like to just be clear about from the beginning. The first is cancer control, which it requires data to plan and evaluate in the national setting. I just want to say, when I talk about cancer control, this is the definition that I'm using. The aims to reduce the incidence, morbidity and mortality of cancer, and to improve the quality of life of cancer patients within the population, and to do that through systematic implementation of programs for prevention, early detection, diagnosis, treatment and end-of-life care. So I won't talk, when I talk about cancer control, that's what I'm talking about. The second thing I wanted to say is that when I'm talking about registries, I talk about population-based registries. As you know, of course, there are other sorts of registries. There are hospital-based registries, there are clinical quality registries, But what I'm talking about today is a population-based registry. That is a registry of cancer in the entire population of a nation or of a defined geographical area, such as a state. So the first thing, I just wanted to give you the picture of how I see cancer registries. And I acknowledge the Global Initiative in Cancer Registry Development leader, Les Mary, from the International Agency for Research on Cancer, for assisting me in producing a number of these slides, including this one. In the population at large, we've got mostly people who are healthy. Within that population, every year, some people are diagnosed with cancer. There are people who've been diagnosed in the past and who are living with cancer. And every year there are people who sadly die from cancer. And this is the picture that we want the registries to capture. We want to be able to put numbers to each of these things and to understand the big picture of cancer in the population. So the measures that we are able to get from a population cancer registry, first of all, and first and foremost, every single person diagnosed with cancer in that population is registered in the registry. This is usually presented in reports as the incidence rate, or the number of new cases of cancer per 100,000 population per annum in that population. And if I had to say one thing, that is the one fundamental thing that we need to get out of a registry, is accurate and complete count of the number of new cases of cancer. People, I'll skip over the middle bit and get to the end, and people who die from cancer, of course, that's also vitally important. That depends very much on having a register of vital statistics in the country. And what registries do is match those people who have been diagnosed with cancer every year that are recorded in their registry with a list of those who have died of cancer, which is from the, in Australia, the National Births, Deaths and Marriages Registry. We've talked a little bit, Chris and I and Dr. Ecker have talked a little bit about the provision of national death registries in the Pacific Islands. I wonder if you'd like to have just a comment on the availability of mortality statistics in the islands, Dr. Ecker.
Yeah, to my understanding, sorry, I really am not familiar with all the countries in the Pacific, but to my understanding, death is something that is registered as part of the vital stats of a country. So when death is registered, it has to be registered with a cause of death. So this is where we can get information about those deaths that are actually caused by cancer. I know that some countries have tidied up their death certificates, and even if cancer is not, the direct cause of death, if it is a contributing factor or a comorbidity, it will also be registered in the death certificate. So that is where this cancer information can be extracted out of death certificates. Thanks.
Thank you very much. And thank you for reminding me, that's a really good point. When we look at the number of cases of cancer who have died, the number of deaths that have occurred within people who have been diagnosed with cancer, of course, we draw the distinction between all-cause mortality and cancer-related mortality, and those two things can be presented separately. So we have everybody diagnosed with cancer registered. We then know of those people who dies each year, and from that we can work out, once we know what the cause of death, we can work out the deaths due to cancer or the mortality rate due to cancer in that population. By definition then, if we know when the person was diagnosed and when the person died, we can work out the survival rate. That is the proportion of people who have survived for a particular period of time. Usually 5 years is given as the measure for survival rate. So those three things combined, the incidence rate of cancer in the population, the mortality rate or the death rate from cancer in the population, and the survival rate of people after they're diagnosed, how long is it on average that they will live, or the percentage of people who will live for a certain number of years, say 5 or 10 years. These are the things that give us, with those three bits of information, we can do so much and understand so much. And I'll go on to give you some examples of that later on in the talk. The fourth thing is the prevalence rate, which is not always presented, but is a very useful measure. And that is the number of people who are living with cancer in the population, having been diagnosed at any time in the past, usually taken to be about 30 years or even longer in the past. This can be calculated from the incidence, that is the number of new cases that come along every year, and the length of time that those people are expected on average to survive. So from those two pieces of information, we can calculate the prevalence rate. And that is a very important statistic. So in Australia, there are close to, in Queensland alone, my state, close to 250,000 people living today with cancer, having had a cancer diagnosis in the past. That is a very important statistic because that is really what depends on that determines the costs and the level of supportive care services that are required for patients with cancer. So these are the things that we have a registry for. And I've just talked about all of those things, giving us it really is, population-based cancer registries are the absolute foundation of cancer control, the only way to get that complete unbiased picture of incidence, mortality and survival in the population. So I think I've done my job. I hope I've convinced everybody of why we have a cancer registry. But just to tell you, and this, for the rest of the talk, I'll just go briefly through the three main things that we can do with a cancer registry, or the three main purposes that are served by a cancer registry, and then get into some examples. I'm very happy if people want to stop me also and ask questions as we go. So we've talked about this already, number one, to describe the big picture of cancer in the population. What is the situation in this country, in this population, to do with cancer now, and especially changes over time? When we talk about the big picture, we've talked about these measures. We look at those by the other things that are collected on patients with cancer for the registry: the age, the sex, the type of cancer, where they live, for example, how far from a capital city they might live, and the socioeconomic status of that patient. All of these things can be reported to describe the big picture. Just let me turn off that annoying noise. Thank you. So this is, Chris has mentioned that my interest for many years has been in skin cancer. In Queensland, where I live, we have the highest rate in the whole world in this state of melanoma, cutaneous melanoma of the skin. This is, we have had a cancer registry, a population cancer registry in Queensland since the early 1980s. And so we've been able to track the incidence. This is the number of new cases of melanoma occurring in this population of Queensland. We have about 4 million people, 4.5 million people in total in Queensland. This is men only, because the rates are different for women. So this is looking at the incidence rate from about 1982 until 2010 of invasive and in situ, which is an earlier form of melanoma in Queensland. And you might think, well, that is really bad news, because that's just going up as fast as you can see there. But it's not such bad news when you look at the more finer detail of this. We divided the total number of cases into melanomas that were invasive. That is, they had invaded already through the basal layer in the skin and would potentially metastasize to other parts of the body if they're not removed. We separated out the invasive from the in situ, which are very superficial melanomas, not yet invaded through deeper into the deeper layers of the skin. And this is not such a bad story after all, because awareness campaigns have begun and have been running in Queensland since about 1985. But that is teaching the population how to recognise a melanoma, when they should go to their doctor. It's all about change. If they see anything on their skin changing, go straight to a doctor and have it investigated. And people have done that in Queensland. And the result, as you can see, is that there's been a huge increase in very early melanomas, but finally, beginning in about 1985, a beginning of a drop-off in invasive melanomas. And without that registry, we wouldn't have understood that. So we can see that the awareness campaigns have actually had an impact. Another way that we've used the data is looking at survival for lung cancer in Queensland and separated out according to where patients lived. And again, as you can see, the source is the Queensland Cancer Register. So the survival, 0.2 means that patients with lung cancer survive only 20% as well as patients without, as people without lung cancer. That's relative survival, which we've calculated from the registry. Relative survival from lung cancer if you live in a city is much better than if you live in the inner regional parts of the state. Even worse if you live in outer regional, and worst of all, if you live in a remote part of the state. That was a wake-up call to try to understand why it is that people survive within the same state so differently from the same disease, just depending on where they live. So again, these are the sorts of questions that we can get from the registry. And I've really started to talk then about actions, how we can guide and plan cancer control measures based on registry data. So this is a very famous paper. This was published in the New England Journal of Medicine. And I'll just show you the green line at the bottom are girls who were vaccinated under the age of 17 with the HPV vaccination. The middling line were those women vaccinated between the ages of 17 and 30 with HPV, the virus that causes the majority of cervical cancer. And the brown line are women who were not vaccinated at any time during their lives. The National Swedish Cancer Register combined with the National Vaccination Register was able to produce these data. And this was really the information that showed the world that HPV vaccination halves. You can see that this is the rate of cervical cancer amongst people vaccinated when they're young, and this is the rate of cervical cancer among people who are not vaccinated, almost double in the end. So this was really very strong evidence that HPV vaccination, prevention of cancer and screening works in the world. Again, without registries, we wouldn't have known this. Chris has mentioned my role in the Australian Childhood Cancer Registry. This is a lovely picture of our data manager, Lisa. And we've had the Childhood Cancer Registry, which registers all cases of childhood cancer that is under the age of 15 in the whole of Australia. We have that centralised in one place. This is how we do that. Here we are based in Brisbane. Sorry, it's gone a bit north there, but Brisbane, that's supposed to be Brisbane. And I've made that a little bit larger than it is. You'll have to forgive me, but that is my hometown. We fly across the country. There are 9 major paediatric oncology hospitals around Australia. And Lisa and her colleagues fly to each of these hospitals and collect information, detailed information on every childhood cancer case diagnosed in Australia. So we are very, very proud of having that resource. And one of the things that we've been able to show, because the registry has been running for so long, what this slide is talking about is the survival of acute myeloid leukemia over, let me just go back. Over the time since diagnosis. So if a patient is diagnosed at this point here, sorry, the photograph has blocked out the 0, but this is at diagnosis. And then as time goes on, this is 1 year after diagnosis. You can see that not all of the patients sadly have survived to 1 year. 2 years after diagnosis, survival is dropping. 3, 4, and 5 years after diagnosis. Patients diagnosed between 1983 and 1993, only 43% were still alive at 5 years. Now, fast forward to 2004 to 2013, 75% of children diagnosed with acute myeloid leukemia under the age of 15 survived 5 years. So this is really strong evidence that treatment is improving. Diagnosis and treatment are improving over time in this population. Planning cancer treatment services, of course, is extremely important, and a job of cancer registries to inform that for planning both hospitals, equipment, supplies, and very importantly, the human workforce. We published a paper on the incidence of childhood cancer in Australia and projected those numbers through to 2035 to show that there would be a 7% increase in the number of childhood cancer cases over the next 20 years. This is important information for our hospitals and for our workforce in terms of training paediatric oncologists. So I can give you this example as, again, a way that cancer registries can support cancer control and planning. And this is just illustrating that this was because there are so few childhood cancer cases, fortunately, the numbers go up and down a little bit, but you can see there's been a general trend. And then this blue line is where we expect to be by 2035, with a confidence interval around it of the bottom line confidence interval in brown and the top one in green. And finally, why would you want a registry? Well, to do research, to explore and answer questions. These are some examples of studies that we have done, again, with the Childhood Cancer Registry. And I just draw your attention to the one in the top left, looking at second primary cancers. That is, patients who have had childhood cancer under the age of 15, who have gone through their treatment and gone on to live lives, but then are diagnosed with a second primary cancer. And the risk of that happening in the Australian population, at least, is that they have about a 4 times increased risk of being diagnosed with a second cancer, having had cancer as a child. That is causing some, obviously, concern. Part of the reason is because of the treatment that is received as children. And so much more work now will be done on trying to maintain the good survival that we've achieved, but have treatments that are less toxic to cells. And this is what I was mentioning in the beginning. I really wanted to show you an example here of a living output from a cancer registry. What I'm going to show you is based on a compilation or a collapsing together of all of the registry data from each of the states and territories in Australia. And this was produced by the Cancer Council Queensland. So I do hope that this will come up on my screen. Can you see that?
We can see your opening slide in the PowerPoint presentation window.
Oh, you can't see the, let me stop sharing and let me come back again. And see if you can see. Can you see that?
Yes, I think that's the one.
Wonderful.
Australian
So this is
Cancer Atlas.
The Australian Cancer Atlas, and I'm going to click it to start. And this is an atlas which looks at the incidence rate, that's what we're looking at now, of cancer in Australia on the basis of small areas called SA2s, which are about the size of a postcode in Australia. So there are 2,000 SA2s, which are little geographical areas around Australia. We've looked at the incidence of cancer within each of those, and we've mapped it. This is all cancers. We've done this for cancer incidence and also cancer survival or the risk of death. I'm going to show you now what the map looks like if we pick melanoma. And here is obviously my state of Queensland here, which has the highest rate in the world. So let's see how that looks. Red means very high rates and blue mean very low rates. So you can see that Queensland has much higher rates than the rest of Australia. There's some high rates in northern New South Wales, and that is exactly as we would expect to see because most of the places where skin cancer is diagnosed are in this southeast corner. If we now look at a different cancer, and I'm going to pick cancer of the liver, it's quite a different picture. Cancer of the liver is very common in the Northern Territory and northern parts of Australia, and much less common around the eastern seaboard and, in fact, the western seaboard as well. So this is something that's used now quite a lot to understand. And when I talk about the big picture, this is the big picture of cancer in Australia. I can also now look at deaths, excess deaths. I'm going to pick another cancer. I'm just going to go for cervical cancer. So there's very little difference in cervical cancer deaths around Australia, which is fortunate because HPV vaccination has now been used for a very long time. Diagnoses, though, are still much higher in the northern parts of Australia, similar to liver cancer. So all of these maps help us a great deal with understanding where we need to target services and resources, and also many questions that are answered that are now being asked about why cancer is more common why some cancer is more common in some parts of Australia than in others. I'm going to stop sharing then. And thank you very much for your attention, and I hope that was of some interest. Thank you.
Absolutely. I thought that was very, very interesting, not just because I'm from Australia and understand the data perhaps a little bit more in a more applied sense. It was very interesting, and thank you very much for your time. I open the floor if there's any questions from the participants here. A shy room, perhaps. I do notice that we've got some more people online now from the SPC. There's Marshall Islands that I see as well. So very grateful to have you all here. There's some really interesting cancer registry work in the Northern Pacific as well. Any questions? I think something that I'd like to build on in what Joanne was talking about earlier in the presentation is the importance of linking the cancer registry with some measure of the deaths in society, the civil registration and vital statistics, and also the population in general, like census data. It's not just confined to the health system. And for our countries that are online here, who are thinking of setting up or broadening the cancer registry, it's important to be able to make that link to make the registry data useful, just like we have in Australia there. I did have another question though for you, Joanne, please. If you're just looking at cancer registries in general, do you have any recommendations about what variables around cancer should be collected? It's quite
Absolutely.
a broad question.
There is a recognised national minimum data set that Australia uses for cancer registries, and all registries tried to collect that information. But the obvious things are age and sex, location, and date of diagnosis, and the patient's usual address, not the hospital where they were diagnosed, because they may have come to the hospital for their treatment and diagnosis, but rather the address of where they usually reside. Those are the basic things. In terms of, so there are things about the person and there are things about the cancer. Something that is very that is ideal if there's any measure at all of the stage of cancer at diagnosis, that is extremely useful, because that tells us a great deal about early detection and prevention initiatives and the success or otherwise of those. Stage is a very difficult thing and expensive sometimes to measure, but in some registries, it's even if it was possible, for example, to record whether nodal regions are involved with disease and whether there is distant metastases or not. Those things give you some indication of the spread of the disease at diagnosis. And if that's possible, that would be very, very useful.
Yeah, and that would be really important in the Pacific Islands as well, where a lot of the cancer control initiatives are focused towards the primary prevention and health promotion. That the stage at diagnosis is collected, but why is that so? Why is it expensive? What comes into that?
Usually it requires someone to go through medical records and seek out the information on nodal or more distant metastases. This isn't something that would automatically, I wouldn't think, come to a registry. The nodal involvement would expect be in pathology reports, but I am not, and perhaps Dr. Aitken can give us more information about, or give me more information about this. But the question of pathological diagnosis is also something that needs to be discussed, because without pathology laboratories, it's very difficult to get all cases of cancer, to register all cases of cancer diagnosed in a population. Usually pathology laboratories are one of the main sources of information for cancer registries.
Absolutely, they are. And that's just another challenge that we have in the Pacific. Are there others that have questions for Joanne? There is one question that's come up in the chat that I can see is from Maretta. How useful, this is something I was trying to lead towards in my earlier question, how useful are risk factors such as smoking, alcohol consumption, medical comorbidities as variables in the cancer data?
That's a really great question. And absolutely, those things, any risk factor for cancer is a gem if you're able to collect that information. Again, it's how do you collect this on the population at large that's difficult. Of all cases of cancer diagnosed, how are you going to get that information? But even if it was only for example, patients diagnosed with lung cancer, you ask about their smoking status. If that could be recorded in the registry, that's immensely valuable, as you can imagine, for prevention programs and also for research into the causes of the main attributable causes of cancer in the population. So yes, absolutely. And usually all of these things, the more you can collect, the better. It comes down to the feasibility of collecting it on a population basis and the cost of collecting it.
I hope that answers your question, Maretta. If you've got anything to follow up, do put something in the chat there. One last
vaccination,
thing
sorry, Chris, if I could just say
Go ahead.
vaccination status also. Linking, I'm not sure if you have screening registers in the Pacific, but to be able to link the cancer registry with a registry of screening, as was done in the study we talked about with HPV vaccination, you can then look at outcomes for people who have been vaccinated versus those who have not been vaccinated, which also is a very good indication of, well, it gives you information for cancer control in that population.
Yeah, that's interesting as well, that the team that are online from Vanuatu, there's not specifically HPV vaccination, an HPV vaccination program there at the moment, but there is some really good screening work being done. And the registry for screening and tracking of the women that they have in Vanuatu is really great, and we're hoping that that will be able to contribute towards the cancer registry as that develops as well. It's kind of a launching place for that. So I'll move on in that case and introduce Dr. Ecker, unless there's any other questions. All righty. So Dr. Ecker, if you are able to share your slides, that would be fantastic. Well, I think Dr. Ecker is well known to a lot of the people in the Pacific, certainly some who are online here, because she's one of the very few general pathologists that we have in the Pacific Islands, and she's been chief pathologist in Fiji and Tonga, and helped out with work in a number of the other countries like Samoa. She's currently the SPC's senior laboratory advisor, and really shows her dedication towards improving laboratories and health systems in the Pacific, but through her postgraduate training contribution that she gives with the Fiji National University. I've had the pleasure of working with Dr. Ecker on a mission to Tonga before, and plenty of correspondence since, and she has a wealth of knowledge from within the Pacific that we'll be able to hear from now and compare with what we've heard from Joanne. So I'll leave it to you, Dr. Ecker. Thank you very much.
Yeah, thank you, Chris. Can you hear me well, Chris?
Loud and clear. Please continue.
Yeah, thank you, Joanne, for your presentation, and that has covered half of what I wanted to cover in my presentation. However, I think we have to really hone down to home, Pacific Island countries, and the shortfalls that we have with our cancer registries. Just an overview, as Joanne has already talked about, cancer registry is basically just a data repository that captures information about cancer patients, okay? Patients, demographic, diagnosis, the stage of the disease, if possible, treatments and outcome. Most registries in the world only require registration of malignant or cancerous cases. However, some also require registration of benign tumors, especially those that are known to progress to cancer over time, and also benign tumors of brain, meninges, and pituitary glands, as an example. Cancer registry, as already discussed, captures information from multiple data sources. Okay, hospitals, clinics, pathology lab, that's where the final diagnosis comes. Unfortunately, most countries don't have it, but that should not stop us from proceeding on and establishing a cancer registry. Some patients don't end up with us in the hospital. They do end up seeking care of cancer societies. They prefer to be home, knowing that their disease is too advanced. And if we can capture those informations, the better. Community health workers, medical officers out in the peripheral outer islands, information that comes back from them do contribute to cancer registries. Death certificates, as we've already talked about. Okay. The problem that we have in the region is that most of our countries do not have regulations that mandate our countries to have cancer registry. Unlike developed countries, they have known, the burden, economic burden of cancer in their countries or in their states, and hence the regulation to capture cancer information so that they can direct cancer control in a much better way as what we're having in our countries in the Pacific. What we're seeing in the region is that there's a big difference. The French and the US affiliated countries have got something going on. Okay, there's a the Cancer Council up in the northern US affiliated countries, and the French, of course, have their regulations about cancer registry. So they basically register cancers in their countries, all of the information about cancer patients. We don't have that, but now that we've started, we've faltered, we've restarted. This cancer registry work has been going on for years, and it's the time is now again for us to relook at things and try to strengthen it further. And we are still at the early stage in our organizing this cancer hub or through WHO office, and I'm sure Chris will be able to tell us more about the plans in the near future. Okay, I have been into some Pacific Island countries. One of the countries that I went into, there was this early discussion about developing cancer registry, and there was basically a fight between whether it should sit in the hospital or it should sit with the cancer society. Okay, those are the things that we will be struggling with in deciding where the cancer registry should be sitting. And we should really see what is more convenient to our countries. One of the issue that was, became apparent to me in that particular meeting is that there were concerns about confidentiality, okay, leakage of patients' information, since this is patient information, and we all know, working in health, as far as patient information is concerned, whether we have any regulation or not, they are confidential. We have no right whatsoever to divulge information about any cancer patient, and they come in trust of what we're going to be providing for them in terms of their care and management. They don't expect us to be divulging information to people. So, and the second thing that I, in a problem that I kind of foresee in that particular meeting was that we Pacific Islanders, we are always very protective about our data. There has been instances in which people come in, utilize our data, go and do their publications, get whatever they can, and without any acknowledgement of where the data come from, people who actually collect the data and those kind of things. I would, in the presence of Joanne, I would say that the utility of the data is a lot more than just research. And I'm going to be covering that in this presentation. Thank you. Now, so what are the kind of information that we are supposed to be gathering for cancer registry? It depends. Okay, different cancer registries have different kind of information that they want. Cancer registries that are sitting away from point of care, I would say, or from hospitals, actually don't usually demand as much information as Joanne has been saying. Like Queensland, they are sitting away from the point of care. Hence, they depend on the information that is sent to them. And if they need more information, it's going to cost them money to go and try and collect information. However, in most of our countries in the Pacific, because we have, ministries of health very close to the main hospitals, and sometimes they're just part of the main hospitals, gives us the perfect opportunity to collect as much information as we can, because people in the cancer registry, the people who are working cancer registries can just walk across the records, get the information, fill in all the information that is required in the database, and that's it. There might be a few information that will be lost, especially when we have to register cases that come from outer islands where you will not be able to access their information, all the information from the files. But the setup in the Pacific, if we get the cancer registry to be closer to the hospitals, it will give us a better capture of the information that is required for cancer registries. And of course, we will have to collect other information that comes from the communities, from the cancer societies and other areas that provide care for cancers out there in the community, in order to have a population-based cancer registry. Yeah, but I would say that the setup and the smallness of our setup in the Pacific, it gives us an opportunity to collect good information. So those are the information in this slide. You can see the information that are normally collected, patient demographics, as Joanne has already said, place of birth, diagnosis, date of diagnosis, clinical management that we can easily extract out of the file, type of treatment, treatment outcome, and cause of death. Okay, so how do we utilize cancer data or information that are captured in the cancer registry? Okay, just I'm sure for those of us who are clinicians, just looking at all this information that are captured by the cancer registry, we can just see the opportunities that are there. There's so many ways to interpret, okay, and make something meaningful out of those data that are in this slide. Okay, we can monitor the cancer trend over time. We can look at occurrence of cancers in various communities, determine cancer pattern in various population. We can use the data to guide planning and evaluation of cancer control program, or even just some of us set up a cancer control program in our countries. And the data from cancer registry, there's a lot of trust when it comes to data that comes out of cancer registry, because globally we know that this is where the country data are deposited. Hence, when people, especially when we look for assistance from partners, we will be asked, where is your data? And where does that come from? Is it just from a clinic, or it comes from your population cancer registry? Okay, carries more weight when it comes from a good registry. They said, okay, now we're really looking at the cancer burden. in your country. Hence, if there's going to be assistance, we know the basis in which we are going to be giving assistance for. So it helps set priorities for allocating health resources when we know the true incidence of cancers in our population. Okay, I think if I step out today and I go up to the clinicians in Fiji and I ask what is the incidence of breast cancer in a population, I will get information from CWM, I will get information. These are the clinical data that probably people have been collecting, not every year, but randomly. So, I might get different answers from different doctors, different answers from different nurses, okay? That is because we do not have information that comes out routinely from our cancer registry. There's actually very little utilization of the data that are already collected by our cancer registry. And last is to advance clinical and epidemiological or health operational research. Now, the shortfall of cancer registry in Pacific Island countries, what I would call the fable of the short stories and the vicious cycle. We have been through this cancer registry project so many times, and yet we still cannot sustain it for some reason, okay? And I would say that there is actually a real lack of focus on cancer management in our part of the country, okay? And that is basically due because we lack information on the burden of disease that we have in our country. And why is that? We don't have any registry that collects all this information, okay? Some of us may say, okay, cancer care is too expensive, which is true. This is the reason why we are sending our patients away. We still haven't been able to develop a regional cancer treatment, say, hospital in the region. Okay, we're still looking at cancer treatment as being too expensive, right? We haven't done any cost-benefit analysis. Why is that? Because we lack the information. We do not know how much is being paid by somebody who gets to be treated in Australia, as compared to somebody who's being treated in India, and how much is it to be treated locally, right? So there's still a lot of information that are lost, and I know that the cancer registry is not there to look at money, okay, but information that we can gather out of cancer registry is going to give us, a lead as to how these people are faring as far as cancer, the cancer patients are faring as far as treatment and as far as coming back and the mortality or morbidity after that, recurrence and so on. Cancer treatment kills, okay? One of the reasons why we just wouldn't want to be looking at a cancer case in the region, because we know they get this cytotoxic treatment, they come back with hair loss and all the complications that we have to live through with them in our families. Okay, a lot of us don't like to see that, don't like to be involved in that. Hence, anybody who has cancer, we just said, okay, sorry, this is death sentence, and we just leave it like that. Okay, the reason is that we really haven't got any update on cancer treatment and how effective they are. The lack of information that we have, we do not have any information on treatment in our cancer registry. Okay, lately we have been referring a lot of cases to Australia, New Zealand, and also our cases to India from most of the Pacific Island countries. We've developed that relationship, especially with India, because it's a bit cheaper. Right? Have we ever sit down and evaluate how well the patients coming back from India with their treatment have been doing as compared to those that come from Australia, New Zealand, who've been given cytotoxics? Right? This is a challenge for those of us, clinicians, especially those who are looking at oncology patients. Have we looked into the costs? I know that one of the countries that I've been involved in, patients with breast cancer go and get treated In Australia, they get given all the cytotoxic. There's no rituximab that is given to them because it's expensive, right? And yet patients who go to India get target chemotherapy off the counter. I mean, not really off the counter, but easily given to them, and it's much cheaper, okay? And yet we still haven't made any decision on how to progress in terms of treating or managing our cases in the kind of chemotherapy that they should be receiving, because we're not documenting information about their treatment. They're coming back, the side effects, and how they do in terms of recurrences and longevity when they come back. It will be interesting to see the difference, and it will be able to guide us, you know, which is the best way to do it. Target chemotherapy nowadays, you know, can easily be given at home. They do not need to be out there, you know, away from home for so long. You know, those are the kind of things that we can probably get if we have better information, cancer registry information that will be able to help us in terms of gauging cancer care and control. Joanne was talking about HPV vaccination. You know, Fiji has started vaccination in 2012. It's time we should be looking at our cervical cancer cases now to see the drop. I'm sure it's there, you know, because these were 12-year-old who had it. By now they would be 19, more than that, and sexually active. And are we seeing any problem with them, or are they now free, like most of the like the studies that have been undertaken? There was that in Spain, or no way? Yeah, but anyway, we'll move on. You know, too many people present late. Yes, that's us. That's being Pacific Islander. A lot of people like to sit with their diseases at home. You know, if we know the amount of cancers out there, we would be able to focus our awareness program, health promotion in that area of cancer, and people will have more knowledge, and they'll probably seek assistance, seek help from clinicians early, and they wouldn't have to die with their disease. Okay, lack of human resource to sustain cancer registry. Yes, this is a problem that we see in the region. Okay? Cancer registry is not prioritized. People who are sitting up in health don't see much of priority given. I mean, don't give much of priority given to cancer. Okay, and when we talk about cancer registry, they always say, okay, who is going to be looking after that, right? And I think this is something that we need to keep on telling our policymakers, our administrators, that we will only be able to manage our cancers well if we have the data about our cancers, and that we need people, you know, a bit of prioritization of cancer registry and cancer control. Okay, so what are the burdens of having a cancer? Sorry, what are the benefits of having a cancer registry? Okay, it informs us about the burden of cancer in our society, provides demographic details of different types of cancers that we have. It informs about treatment and treatment outcome, and it informs decision makers in health of the appropriate preventative measures. Okay, better way to manage our clinical management, and also informs, makes us, allows informed decision making on the resources to be allocated to cancer care. It informs our partners. Okay, that most of us, we know that we are in underdeveloped countries, and when we want to put up a big program, we will have to run to our partners for assistance. And if we have good data, yes, you know, that is probably one of the things that our partners will want. It is, you know, the most important thing that our partners will want is for us to give them good data that would come out of our cancer registry. Sorry, that supposed to be reliable data, provides reliable data source for scientific and operational research. Thank you.
Thank you very much, Dr. Aitken. There's a lot to unpack there. I think that was really valuable. Thank you very much for your time to pull that together, especially since I know you're on the back of maybe your third presentation today, maybe more. You've been working very hard, and thank you for your time. So again, opening the floor for questions, or let's start some discussion about how the links between what we've heard from Joanne and from Dr. Aitken between Australia and the Pacific Islands, and then how that can be built on and what can be learned into the Pacific. While people are thinking, I'm just looking at this map that Dr. Aitken has in front of us, which is really very useful. Dr. Aitken was mentioning the Cancer Council of the Pacific Islands, which has a regional type cancer registry. And that's covering what we're looking at here: Palau, Federated States of Micronesia, Republic of the Marshall Islands, American Samoa. If I missed any in there, I feel like I have. In any case, the message to get across there is that there's a number of countries working together, albeit with a lot of help from the USA, to conglomerate all of their data into one registry, and it can then be reported back at such a large scale. Thanks, Martina. Yeah, Guam, CNMI, and your. It's because they don't have a little circle around them in this one here. Okay, but there was one thing which I felt linked, but firstly, anyone got any questions? Please feel free to raise your hand. So I've been working now a bit with a number of the countries in the Pacific Islands, particularly in the South Pacific, on their cancer registries. And one thing which consistently comes up is how to identify a person's location. And that's a real trouble, even when it comes down to address. Dr. Aitken, can you tell us about your experience from the pathology side and the data you get in Fiji and Tonga? How reliable would the location of that person be?
I wish I can answer that question. What usually appears on the laboratory form, this is especially in Tonga, is the address of the person, okay, where the person is coming from before they get into the hospital. I'm sure Sunia will be able to tell us. And if that does not appear on the form, on our report form that goes back, we would, the cancer registry ladies would just walk across and look up information from the records office, or now with a very good health information system that is existing in Tonga, I'm sure they can easily access it from where they sit, information about patient's address. And when I say that, I would think, Sunia will be able to tell us, that is probably their address within Tongatapu, the main island where the main hospital is located. However, if there are, we do receive cases, specimens that come from outer islands as well. The doctors are there and they do the occasional biopsies. And we would capture the information from where they come from. Okay, this is a referred specimen from Vava'u or something like that. But that is probably all that we can say, instead of getting the real, their address or location from Vava'u. That is a starter.
I suppose, for a researcher. You would, if you try and look up information, you might think that there's a big number of certain kind of cancer that comes from a particular island. That might be a start off point, and then you can go on from there. Thank you.
I see, yeah. And we got a comment while you were talking from Martina Inyap about how in FSM they distinguish between current residence, their current address, and a permanent address, which is, say, perhaps, as is my understanding, their outer island or their village of origin. And a similar thing is being done in the Solomon Islands about how to identify their address, what's their permanent province and what's their current address. Because if someone's from an outer island, from, I don't know, Makira Ulawa, then they have to come in to get all their cancer staging and workup done in Honiara. So they might be giving their current address in Honiara, but in fact they live in one of the outer islands. I would be curious if I can throw that to Joanne about, is this trouble that is encountered with Indigenous Australia as well?
Yes, Chris, it is very much so. Address is always difficult, and trying to understand whether that is the usual place of residence or whether someone has just moved to that place because of their diagnosis. I don't have any answers, I'm afraid. We just do the best that we can.
Right. I see. So that's something we all have in common. So we're just doing the best that we can. So there is Vicky's iPhone has raised a hand. Would you like to also introduce yourself, Vicky? Please go ahead.
Hello. Sorry, thanks. My name's Vicky Bennett. I work at the Australian Institute of Health and Welfare, and I'm an advisor to the PHIN network. And thank you both, Joanne and Boulevard Nakavonawai. Very nice presentation. I used to run the HIU in MOH in Fiji, and I've worked much in Tonga, and so I've worked with cancer registries in both of those countries. But it does, I guess, the last comment that you made, Dr. Eka, is that how do we get better partnerships, perhaps with some of our Australian agencies? And I guess Sonia and I were literally yesterday just talking about how we maybe establish a stronger partnership between the institute where I work in Australia, which manages our national cancer data and does all the output reporting, and SPC in the region. And I think this would be a really lovely maybe pilot project to think about, because I know both Tonga and Fiji have been collecting cancer data and morbidity data and mortality data fairly well for at least 15 years, if not more, but very little is done with it. And I think that was one of the strong comments there about, we've collected a lot of information, but it's how we then turn that into useful outputs that are able to be used by those who are in decision-making positions, whether that be donors or local ministers, and getting better priority action for cancer. So I guess I'm putting up my hand to put out my hand in offer of help wherever we can as an organizational partner in this area.
Thanks very much. And it's really great to have someone online from Australia as well. And you clearly have a close connection with the Pacific. You were mentioning Sunya, and Sunya also has his hand up. Please go ahead.
Thanks, Chris. And I think Vicky's, the sooner we get the agreement signed, the better. So let's take that conversation further offline. I think the challenge is that Eka, I probably respond to Eka's presentation and then to your recent question, Chris. I think the challenge that Eka alluded to throughout her excellent presentation is something that we grapple with in, day out, as a regional organization supporting the countries that we initially originated from. So we've transitioned from national now to regional. And unfortunately, if health priorities aren't developed and reflected in a national strategic plan, they get dropped off. And then the default position if for someone for a priority to evolve and germinate is basically driven by a champion. Someone has a interest in cancer, and he or she sees it as their lifetime ambition in that country to set up a cancer registry. So basically, the opportunities to get your area of work on the priority is through a structured approach, through a national health planning process where the country determines that as a priority. And if it misses out that process, then it normally, as we have experienced, is by personal interest driven for a greater and common good. So that's unfortunately the realities in the Pacific, that things get pushed along. In response to your question about the identification of addresses, Chris, I think that's probably looking at it in its most simplistic term. We need to take quite a few steps back, significantly a few steps back, because at the end of the day, you're talking about unique national identifiers. I think Vicky and I know there are not many countries that have a unique health identifier, and therein lies some of the challenges. I mean, you need to be able to identify someone with a unique set of information. At the moment, I know in some jurisdictions in the Pacific, you have more than 6 identifiers. You have one with the Ministry of Education, you have one with the land transport, you have one with the immigration. So probably one of our first roles is to take a step back. If we are realistically going to support an undertaking like a cancer registry, we need to ensure that the ecosystem around that, in terms of governance, in terms of infrastructure, in terms of political and institutional priority, are in place to be able for our aspirations to be achieved. If we don't do it, our chances will be significantly reduced. But then again, those are my reflections. You either do it for a structured way, or you have an individual or individuals or group of people that see the value in it, and through circumstances are able to generate enough political will and resourcing, then things get progressed. But we don't want to. My view is that we shouldn't be leaving it to chance. Ideally, it should be done through a structured and systematic approach. Thank you.
Absolutely. Thanks very much, Sonia. It'd be really interesting to hear from others who are on the call about how, because there are some countries who have who are using a national health identifier, a unique identifier, and some, it's kind of a gradient as to how well that's being used. So it would be great to hear about from people online about how that's being used, and then how that could contribute towards the functions of their cancer registry. I'm just looking at the chat as well. Brett Watson has put something in the chat about having a software platform cloud-based, so there's not necessarily need for local support. I'm just wondering if you could elaborate on that for us, Brett, if you're able.
I'll talk instead of type, it's faster. So at the moment, we've built something, I guess, similar to a cancer registry, but actually around poisoned information. That is being considered for Australia, but also in the Caribbean. And I kind of feel the Caribbean's a very similar pattern to South Pacific, of being a large collection of small islands with a level of cooperation between them. And yeah, when I can't remember who was talking previously, was talking about the Australian Institute of Health and some potential for collaboration there. I was just wondering whether there was any interest in, I guess, something more like a clearinghouse between established registries, and maybe a registry in a box type setup for countries that don't have it.
An interesting concept. And I think some of that has been touched on kind of in our discussions within the Pacific Islands previously. Registry in a box, interesting term to use. No, I don't want to get diverted by that too much. Laura, you have a question?
Not so much a question, but just to basically respond to Brett's comments, which I think is really something worth pondering. Certainly, I think one of the biggest challenge of implementing anything that's on premise, meaning on site, is quite difficult given the lack of infrastructure, the lack of people to support that application. So, looking at a cloud-based option or registry as a service, as an example, is something that has merit to look into. The problem, Brett, is in the Pacific, is that is a connectivity. The quality of service of the internet in the region is still quite constrained, but it is getting better, but I would love to know, I mean, if there is a light solution that is cloud-based, it is certainly something that we should really, really explore instead of, instead of basically limiting ourselves and thinking that everything has to be done on site. It doesn't have to be done on site. All we need is just making sure that the quality of service of the internet is good. And that's it. So
yeah, the stuff we did was obviously Caribbean's not awesome coverage either, though it's got better since COVID. And Africa is very hit and miss as well. So yeah, that's copable. I guess it's not really on topic for this, but anyone want to chat with me, happy to take the conversation.
I certainly would love to. This is something that I would like to see if we can actually even explore, not just for WHO, but for PHIN as well. So, and maybe this is something that Sunya would like to get into as well. I see his hands up. Thanks.
Go ahead, Sunya.
Oh, thank you. I think the concept of cloud-based is the way forward. But again, a lot of the Pacific countries are very, very super sensitive about the information, the ownership of this information. So again, those sort of ecosystem issues need to be addressed in terms of whatever legislation, whatever agreements for the national data to be hosted offshore. And again, once we can get those cleared, then this is, I think, the way forward. Thank you.
Thanks very much, Sunya. I was thinking the same thing as they were talking, but I'm just wondering if Brett and Laura were referring to a cloud-based domestic registry, or were you referring to something international?
Well, I mean, at least from my perspective, it would be great to do something international. So that way, all the data structures are the same format, so that there's comparability. And of course, you were all using the same minimum data standards. But Sunya certainly has a good point, that in many Pacific countries, there is a lack of laws that allows them to basically put it this way, if there really isn't a lot of regulatory regulations around hosting anything on the cloud, that could be a good thing in the sense that go ahead and host it on the cloud, or it can be a bad thing in which everything has to be done in country. Fiji, for example, is one country where they will not put anything on the public cloud. But countries like the Solomons, Vanuatu, I mean, they don't really have much regulation, and they actually have some of their, public health information actually running on the cloud. So, but Brett, I'm going to send you an email, and we can chat and see how we can progress this even further.
Sounds good.
Thanks.
Great. Thanks very much. And then if I can make a link with that towards Australia, I'm just in case the people online are unfamiliar, the cancer registries, the different states in Australia, all, and I hope Joanne will let me know if I'm wrong here, the different states in Australia all run their own different registries. And so to put together what we saw on the screen at the end of Joanne's presentation with the map of Australia requires that working together of the different registries. And then there are the confidentiality issues. So Joanne, am I right with that? And then how is that overcome in Australia?
Yes, Chris, you are correct. There are 8 separate state separate registries, one for each of our 8 states and territories. Once a year, the registries provide all of their information to the Australian Institute of Health and Welfare, who combine those into one large database called the Australian Cancer Database. They also check to see that the same person isn't in there twice. For example, if someone was in northern New South Wales and was also recorded in Queensland, we don't want that person to appear twice if it's only one case of cancer. So they deduplicate and come up with a final listing of all cases of cancer diagnosed in the nation of Australia. In terms of privacy, I'm not sure when we have privacy laws, but the main thing that when people want to do research such as we did with the Australian Cancer Atlas, of course, the information doesn't have personal consent, because if you asked everybody in Australia who had cancer to give their consent, you'd never get any of this sort of research done within 50 years. So we do have, if an ethics committee provides approval, all of our research projects go through an ethics committee, and then each of the states and territories has to agree to their data being used for a project, and then it can go ahead, such as with our cancer app.
Thanks, Joanne. You just, you're not on mute, but we did lose audio. So I don't know if you had concluded there.
Can you still hear me?
I can hear you now.
Okay. Vicky's got something, you would be able to comment on the Australian Cancer Database, Vicky.
Yeah, thanks. So the AHW does, they in fact get named and identified data, and that is because legislation exists in Australia that allows cancer as a very unique data set to actually be provided in an identifiable way. That has huge benefits because it allows us to more accurately link to the National Death Index data to ensure we can report properly on survival rates. And one of the other great benefits is we have the screening register data as well with us at the national repository. So a lot of our analysis is able to bring in screening and comparing that to early diagnosis, so staging of disease versus survival rates, what the reason for death, whether it's based on the cancer or not. We also have all of the hospitals' morbidity data, so we're able to look at, I guess, people's journeys through the health system. And I think that's why bringing things together at the national level, even if you say in some of the Pacific countries were to collect it at the provincial level initially, just really does allow that to create, where you bring the data sets together, you can create a bigger picture looking at the elephant from different angles, if you like. So in Australia, that is definitely the case. Obviously, the reuse of that information, as Joanne said, we have an ethics committee at the Institute, and it considers all applications from researchers for use of those type of data assets as well. So there is a very strict and structured process for its secondary use for purposes other than at national and local level reporting.
Thanks very much, Vicky. And so that kind of highlights as well, or starts to point towards, if the Pacific were looking at something like this, then it seems like there would need to be a Pacific-wide agency which acts kind of like the Institute of Health and Welfare does in Australia, but also has the ability to cross international borders rather than just state borders with a lot of different information. I don't think it's impossible, but it is something that would be challenging. And as Sunya has said earlier, it would take, was it Sunya? Would take someone to dedicate their life to making sure that this is the way things end up. This is how we can get a working cancer registry. Not impossible, but it's a big task, that's for sure. Has anyone got anything else that would like to contribute? it talking about that regional collaboration kind of works into something that Dr. Ecker mentioned, which I can build on, which was about a cancer registry hub, which gets spoken about a lot, particularly at the level of the WHO and the SPC IARC. And it's the cancer registry hub is something which it's still germinating as a technical support hub, which is based here in Suva at the WHO. And it is germinating, but still it's the function remains for cancer registry support. And what we might like to think about and work towards is some kind of a cancer registry network, which could be the secretariat, or the guidance could be out of the office here. But it's really a Pacific Island-based network. So that's just my closing comment there. I would like to thank very much Professor Joanne Aitken from the Cancer Council of Queensland and Dr. Buadromo from the Pacific Community, the SPC. We are really grateful for you both to be able to take the time from very busy schedules to be able to help us with understanding why a cancer registry. Before we go, unless there's any other comments, we do have a quick poll to understand more about how people would like the direction of this webinar series to go in. Is Evelyn still online? Excellent. Thank you, Evelyn. Would you like to take the floor?
Thanks, Chris, and good afternoon, everyone. Just a quick survey to get your feedback on today's excellent presentations and discussions. I would request if you could join slido.com. So if you have your mobile device or on your laptops, please enter slido.com into the browser and use the meeting code 063536 to log in. It's only 5 quick questions, so we will be done with this in the blink of an eye, I promise. Okay, so I'll begin the poll. So while you're still finding your way into Slido, all you have to do is join Slido by typing in slido.com, as you can see on the screen, and entering the meeting code, which is 063536. And you will see the first question appear: how useful was this webinar? 5 being excellent and 1 being the opposite.
And Dr. Ecker and Professor Aitken, feel free to join in as well.
Just give everyone a bit more time to log on.
Yeah, I'm having a little trouble. That's my phone, my fault.
So if you're still finding trouble, all you need to do is type in slido.com into a web page browser and enter the meeting code 063536.
If I was clever, then we could do the maths of how many people have put in their responses. Do you have that?
We have 10 people online at the moment, 11 that have entered the Slido poll. So if you look at your top right-hand corner, you'll see the number of people that log in. So, oh, we're at 12 now.
It's looking fairly positive, I would say.
Okay, so
Thank you,
shall we move
everyone.
on to the next question? And the next question is, what would you most like to learn regarding cancer registration? You can select more than one answer here. So you can select more than one. What are some of the topics that you'd like to learn more about regarding cancer registration? You can select one or more than one or all of them and give Chris more work.
Hey. Starting to think this was a bad idea.
I'm just looking at the answers right now, and it is really looking, yeah, the country corporation is fantastic.
There is I noticed it is on the phone, but it's not showing up here. The last one, which was nothing at all about cancer registration. Don't want to learn about it. So I just wanted to make sure that people realize down the bottom, if you don't want to learn about cancer registries at all, we're open-minded to that.
All right, so I'll move on to the next question. This webinar provided me with knowledge and skills that would change my work in cancer registration. And those are your options. So for this question, this webinar provided me with knowledge and skills that will change my work in cancer registration. Okay, moving on to the next question. I think majority agree for this one, right? So do you feel that this webinar content applied to your current setting? Very easy, yes or no. And feel free to contact Chris for any other suggestions or comments that you may have. And I believe, Chris, you will be circulating a link later.
Yes, that's right. I'll make sure that everyone can get copies of the slides. If that's okay, I actually didn't ask Joanne and Dr. Aitken prior. So if that's all right, I would like to be able to share the slides, and this is being recorded so we can share that as well.
Yes, of course.
Okay, we're almost finishing.
Yep.
We're almost finishing.
It's okay, Chris.
Thank you.
So for this question, the webinar provided me with new knowledge and skills that are relevant to my country and my work in cancer registration. So this webinar provided me with new knowledge and skills that are relevant to my country and my work in cancer registration. Right. And for the last question, and we are done. Okay, I'll just, oh, still have people, 15. All right. And the last question, what are you looking forward to this weekend? It's Friday. Use one word to describe what are you looking forward to this weekend. And while you're filling in your answers, I hand back to you, Chris. Thank you. And have a good weekend, everyone.
Wait, what? Sorry. So someone's looking forward to cancer this weekend. This is not how we wanted to end. Let's focus more on party, break, relaxing. That's great. Thank you for everybody for your inputs. I think it was a great discussion, but most of all, I'm very grateful to Professor Joanne Aitken and Dr. Buadromo. Thank you for joining us.
Thank you. It's been a great pleasure to be here.
And I hope we can have you back at some stage in the future for some more interesting topics on cancer registration.
Thank you very much, Chris.
Thank you.
Thank you.
Goodbye, everybody.
Thank you. Goodbye, everyone. Bye.
Thanks, Chris.
Goodbye.
Bye.
Looks like everyone is looking forward to some relaxing and socializing.